It's my pleasure to welcome to the podium Dr. Ajita, Prabhu, who comes here from Cleveland Clinic. She'll be discussing robotic hernia repair. Is it worth it to my patients and to me to adopt robotic hernia repair?
Thanks, Gina, and I'd like to thank Gina and Yuri for inviting me to be here today. I'm going to be giving a talk on robotic hernia repair. Is it worth it for me to adopt and for my patients as well? Obviously, this is a controversial topic, and it's something that comes up a lot. So here are my disclosures. Today, I want to share with you my philosophical bent on this, which may vary substantially from a lot of you in the crowd. But first, I want to start with really the crux of the discussion is how do I decide to introduce a new technology into my practice? So when I go through this, the things that I'm looking for in a new technology, similarly to what Yuri said with the TAR, is the technique generalizable? Is it something that everybody will be able to do? Is it reproducible? Is it available to everybody? So do I have access to the technology when I need it? Do I have a clear indication for using the technology? And finally, does it add value in terms of outcomes as relate to cost? Obviously, with a robot, there are probably several of the things on this list that we can check off. I'm not sure we're clear yet on the indications, and I'm also not sure if it adds value yet, and that's some of what I want to discuss. In terms of marketing and in terms of the broader discussion in the general surgery population, some of the pros that we think about with robotic hernia surgery include 3D imaging, improved dexterity for a surgeon, so the ability to suture intracorporeally, and potentially improved surgeon ergonomics, including decrease of fatigue and chronic injury from repetitive motion. In terms of cons, some of the things that, some of the negative reviews are feasibility in terms of getting access to the robot, potentially cost, although we don't have a great amount of data on that yet. There's a lack of long-term outcomes, and technology, frankly, is still early. There are a bunch of cords that are fairly cumbersome. Instrument exchange can be challenging, and docking, even though it gets better with time, as most surgeons will tell you, can be difficult to learn. Nevertheless, what we do see is an expanding rate of adoption of hernia repair across the United States year over year, despite the lack of some of these important data points. And we're not the only ones that notice that. So there are news articles, and it's not just in general surgery news, where the discussion is that robotic adoption has far outstripped data to support it. And again, that's what we see in the rate of adoption in hospitals across the United States. So one of the things that I wanted to do is step back for a second and take a look at what the data is that already exists. And I'm going to give you a hint, which is that I'm going to be able to cover it in less than half of my time on this podium. So for robotic inguinal hernia repair, if you look across year to year, this is a slide borrowed by one of the industry representatives for robotics. The top line represents open inguinal hernia repair, and you can see that obviously that's the greatest adopted technique. However, it's plateaued in its adoption. It's the most commonly performed procedure. If you look at laparoscopic, it's in the middle. Towards the bottom there, and we know that there's only about a 25% penetrance of laparoscopic inguinal hernia repair. However, if you look at the bottom line, you can see that robotics has had a sharp uptick, and you can see that again a little bit more closely between the years of 2011 and 2015. You can see there's been an exponential increase. Despite the lack of numbers on the y-axis, the robotic adoption has been substantial. Now, what if we step back and look at the amount of literature to support that? If you look at my y-axis on this graph that I made, you can see that it goes to 10. And in the year of 2016, and I'm speaking specifically about publications that come from general surgeons, not including urologists taking or doing these types of publications. You can see in the year 2016, there was a whopping total of 2 studies that came out. If you look at the evidence specifically by those studies, there's one study that's a description of technique published in the Journal of Surgical Oncology in 2015. Feasibility was described by Dominguez and his group in surgical endoscopy in 2016 in a cohort of 123 patients. In terms of comparative studies, there's one to my knowledge comparing RTAP versus LAPTAP, 39 patients in the robotic group versus 24 patients in the laparoscopic group. They looked at operative times, recovery room times, pain, and cost. Not surprisingly, operative times were longer in the robotic group than in the laparoscopic group. In terms of recovery room time and pain, they appeared to be less for RTAP, but again, these are fairly small groups of patients, and they looked at direct cost and contribution margins, which were the same for both groups. So when you step back and look at robotic inguinal hernia in terms of data, we can say possibly this enables open surgeons to offer an MIS option. Not sure on that one. There's a paucity of general surgery literature, as I mentioned. The only comparative study is retrospective with small groups of patients. So we need more cost data, we need long-term outcomes and complication data and recurrence rates for a true comparison, and we're just not there yet. I will add that at my institution, there's currently an ongoing multi-center prospective randomized controlled trial comparing robotic inguinal hernia repair to laparoscopic inguinal hernia repair. And additionally, the America's Hernia Society Quality Collaborative is currently collecting data on minimally invasive open techniques for inguinal hernia repair. So data is coming. So what about robotic ventral hernia repair? Again, if you look at the curve for rate of adoption of robotic ventral hernia repair, you can see it looks very similar to the inguinal one. And again, if you look at the curve describing literature or specific publications as they relate to ventral hernia, you can see that the curve is relatively flat and tops out at the number 3 for the year 2016. If you look at the evidence more closely for ventral hernia repair, there are 2 feasibility studies which were published in 2012 and 2015. And then there are some case series published by Yusuf Kudsi and, again, Dr. Gonzalez in 2015 and 2016. But long-term follow-up is still needed for complications and recurrence rates. I'm not able to advance my slide. There we go. If you look at comparative studies, there was a recent study by Linda Zhang's group comparing laparoscopic IPOM versus robotic IPOM, which is a retrospective review of small defects, which are 2 to 3 centimeters as outpatients. The operative time, again, not surprisingly, was longer for the robotic cases than for the laparoscopic cases. Complication rates were similar between the lap ventral and robotic ventral groups. Jeremy Warren and his group published a study in surgical endoscopy in 2016, comparing laparoscopic IPOM in 103 patients versus 53 robotic retromuscular hernia repairs. They looked at perioperative morbidity, which was similar between the 2 groups, and then they looked at surgical site occurrences and infection, and what they found was a higher rate of surgical site occurrences in the robotic group, likely related to seromas. Ultimately, their upshot was that there was a median length of stay that was lower in the robotic group versus the laparoscopic group, and the difference was 1 day total, and this was statistically significant. And then the direct hospital cost was the same. There is some emerging data from the America's Hernia Society Quality Collaborative, and one of the studies that I showed 2 days ago was Alfie Carbonell that will be coming out in Annals of Surgery in the near future. They examined outcomes between robotic-assisted approach for retromuscular ventral hernia repair as compared to open approach for retromuscular ventral hernia repair. And in 2 large, fairly well-matched cohorts, they looked at length of stay as the primary outcome and ultimately found a 1 day shorter length of stay in the robotic group versus the open group. Additionally, we presented the other day some unpublished data from the AHSQC where we compared laparoscopic IPOM versus robotic IPOM, again with a primary outcome variable being length of stay. In 2 well-matched large groups, we found that there was a 1 day length of stay difference favoring the robotic group, and it was a difference from 1 day to 0 days stay in the hospital. So again, it's not a slam dunk, it's all emerging data. It's certainly promising, but it's certainly still a very small volume of data. But if we take a step back from that and change our framework just a little bit and start to think about some of the philosophical considerations with adopting hernia repair on the robot into our practices, the first question we really ought to be asking ourselves is there any benefit to the patients? So I try to think about this in a more specific way, and when I consider ventral hernia repair, there may be a potential benefit in going from laparoscopic ventral hernia repair to robotic ventral hernia repair, and that benefit may be shorter hospital length of stay and potentially less pain. Again, not enough data to support that. For inguinal hernia repair and TAR, there may be a benefit to take the operation from open to robotic, again, because now we're offering a minimally invasive operation where before the offer was always a larger incision. So potentially shorter hospital length of stay and potentially less pain. But ultimately, for all of these procedures, the long-term outcomes remain unclear, and I think it's important to say that and to recognize that, particularly in the context of considering adopting this technology into your practice. And costs remain difficult to determine. So then I also want to talk about the opportunity cost for the surgeon themselves. So, something to think about is it's not just a short discussion about adopting the robot into your practice. There's a substantial time investment that's involved in getting on the robot. particularly related to getting on the simulator and practicing there, and then performing case observations, which may or may not involve travel, depending on what your setup is and who else is doing robotics around you. And then finally, there's case proctoring before you get started. For a busy general surgeon practice, it may not be possible to take the days off from work to get all this stuff ready to go. That said, once you get on the robot, the learning curve is substantial and it's steep. And I say this humbly as somebody who I would say is well-skilled and well-trained in laparoscopy. The learning curve for robotics was fairly steep for me personally, and I think it may be for many surgeons. One thing that Dr. Dimmick said when he was presenting the other day on adopting new technology is that the learning curve may also be represented as the unnecessary patient harm curve, and that's another way to think about things, which is not to say that there's an undue amount of morbidity associated with these operations, but as we become better, there's a time in which we're not better, and there's a time in which perhaps technically the operations may not be performed as well as we want them to be. And finally, access to the robot. There's a lot of time investment that's spent up front getting trained on the robot, but then if you don't have access and you're not able to continually or frequently perform operations on the robot, your ability to improve and get up the learning curve in a faster or more efficient demeanor may not happen. So I say these things not necessarily to say that one shouldn't train on the robot, but I think it's important to approach it in a responsible way and to be aware that it's an investment before you start. And then what is the return on the investment for the surgeon? This is another thing. And I put in here some of the discussions that I've had with some of my colleagues. And I say this in fairness as somebody who is on the robot and performs robotic operations. So what do surgeons say about the robot? Why is it worth it to learn these things? Well, number one, it's potentially a marketing tool to stay competitive in a market where many surgeons are adopting this into their practice. Another is intracorporeal suturing, which may be facilitated by the wristed motion of the robot, where previously surgeons have struggled with laparoscopy in that regard. Ergonomics may be an improvement, and also it may potentially enable open surgeons to perform minimally invasive surgery, which is something that I've heard fairly frequently. This is a video that I borrowed from Conrad Ballitzer, who frequently likes to make some tongue-in-cheek references to the challenging ergonomics of laparoscopy. Obviously, he's exaggerated his motions for this little video. But one of the things that Conrad likes to talk about is the ergonomics and how much easier that is on the robot. And I would just counter by saying, one of the things that we need to be careful about is just because a lot of people say something, it doesn't necessarily mean in full regard that it's true, that it'll take away all our ergonomic struggles from laparoscopy. So here's a study published in Surgical Endoscopy where they surveyed, I believe, almost 440 surgeons, and they were basically looking at outcomes for ergonomics for those surgeons, and these surgeons were regularly practicing robotics. And what they determined was that although robotic surgery does provide better ergonomics as compared to laparoscopy, about almost 56 or 60% of surgeons regularly practicing on the robot still experienced ergonomic difficulty related to the robot, specifically in terms of neck pain, finger pain, and eye strain related to the console. Granted, there's a small body of literature, but there is some burgeoning literature to suggest that although the robot improves our ergonomics, it may not take away all of these difficulties. The other myth that I would like to bust is the myth that taking an open surgeon and putting them on the robot will suddenly enable them to be able to perform an inguinal hernia in a minimally invasive approach. David Chen gave a nice talk the other day on the anatomy for the minimally invasive inguinal hernia repair approach, and I think we can all agree that the anatomy is fairly complex for these operations. And furthermore, I would like to just point out that it's taking one operation and having the surgeon do a completely different operation. So just adding the robot doesn't save the surgeon having to learn a completely different operation, completely different anatomy, and everything else. That being said, I think it may facilitate peritoneal closure in terms of suturing, but I would like to just say it's a little bit of a tough sell for me personally that it will take an open surgeon and enable them to do minimally invasive surgery in and of itself based on the technology. Because the plural of anecdote is not data. So just because we say all of these things, it doesn't mean that any of them have been necessarily proven or are there for the long term. So where are we in 2017? Is it worth it to adopt this in your practice? Here are some of the things that I can say. Adoption continues to outstrip supporting evidence, and that's not necessarily a terrible thing. If you look at laparoscopic hernia repair, there was about a 10-year lag between the rapid increase of adoption of that until good data came out. So I don't think it's necessarily a terrible thing. I think we just need to recognize it and accept it. Evidence is on its way, but we need to be a little bit patient. This is an important intersection where we have widespread adoption of this technology. There's a growing body of literature, and I think the competing platforms are going to drive costs down, and they'll drive improvement in technology as well. So it's still very early. I do think robotic hernia surgery is here to stay, and I think that over time we'll be able to determine who the best candidates are for which operations. So is it worth it to adopt it? Maybe. I think you have to go into it with your eyes wide open. You have to have a clear understanding of your reason for adopting it into your practice. Follow your patients. Outcomes are likely best achieved through registry-based data. While the experience of one surgeon is certainly valuable, the experience of many surgeons is powerful. And we all must be willing to abandon it if long-term data isn't good. Thank you.
Thank you very much, Dr. Prabhu. So we've heard at this meeting about EPAs and the earlier specialization and autonomy in surgery training. How do you think robotic surgery fits into this? There's certainly we're hearing of interest of surgery residency applicants and of residents themselves, but a broader number of things they have to learn in a short amount of time.
So I think that's an interesting question, and I think the first part of the question may be, should we be training residents on the robot at all? And as we all know, the adoption of robotics has increased exponentially. So to me, I think it is a good idea probably to at least expose residents to the robot. And then if we're going to do that, to me, I think to take it one step farther would be to make sure that their education is solid and that we have a framework on which to hang that. Similar to the way that fundamentals of laparoscopic surgery has become a requirement for them, it may be in the future that fundamentals of robotic surgery or that type of framework may be necessary in doing that. I also agree that in 5 years, it's a short time to learn a lot of different things. And one of the most important things that we have to teach them is how to become a good surgeon, which just involves cutting and sewing and stopping bleeding and making good decisions. So I think we start with those things. And I think that if we are able to make a uniform and reproducible curriculum for them, as many good programs such as UAB are already doing, that may be the way to move forward with that.
Ajita, great talk. I have a question. Can you talk about your personal, emotional sort of, for somebody who's been doing it for a while, how you viewed it before you started, while you're doing it? I saw your graph with yays and no's and fews, and it sounds like that was the sounds that you were actually making. But literally, how have you evolved before you kind of got curious about the technique, when you were learning, when you were doing it, where you are now?
Thanks, Yuri. That's actually a terrific question that I've never been asked before. And what I will say is that I am very honest about my emotional journey with the robot. It started with an interest and a curiosity as to whether that technology had any application for our field, and knowing that there was a paucity of literature out there. So it started initially with an academic curiosity. When I first started, I certainly felt acutely that there was a huge time investment into this, and I was surprised by the need to get on the robot in short intervals of time. The longer I went between cases, the harder it was and the more frustrating it was. And then as I started to do more procedures and I started to schedule them more frequently and closer together, I started to work with my team a little bit more to streamline who was in the room, how they were helping me, and where our stumbling blocks were. We were quickly able to overcome some of the hurdles that we initially started with, and the frustration level started to go way down. And then I started to be able to appreciate the technology a little bit more for itself, and also to be able to challenge myself a little bit more in terms of harder cases. So I think no doubt there are ups and downs. I think overcoming the frustration has to do with coming at it in an organized type of way. Once we were able to break operations down into steps and times for each operation or for each operative step, I think that also diminished a lot of the frustration because I knew exactly how it was going to go and when I was going to have a threshold to change my plan. So I think the key is to keep at it and to be invested in it from the beginning and not to just give it up and walk away if you get frustrated.
Great. We have a question for the microphone.
Hi, Suzanne Warner, City of Hope, California. A lot of us are no stranger to innovation in our own clinics, and as we talk to patients about it, I want to know what you say to your patients when you're in the steep part of, or the unnecessary patient harm part of your learning curve, when you're consenting them. Do you tell them that they're going to be the first one that you've done, or the second one, or the third one? Do you tell them that for the first two you were cursing at your, OR staff, or they were cursing under their breath about you? Do you tell them about all these frustrations as you move forward? How do you deal with the ethics of that?
Thanks. So yes, I would say that I am very, very open and I'm very honest with my patients when I'm offering them this operation. And in the steep part of the curve, I was no different about it. What I will say is that I let them know, I never push any patient towards any approach ever. That's number one. If I think that they will do better with one approach versus another, I will still tell them about all of the approaches and why I think they may benefit from one versus another. I will also say in a very direct manner, I don't have data to support that your long-term outcome for a robotic inguinal hernia repair would be better than, say, for instance, a laparoscopic inguinal hernia repair. What I can say is that the technique is almost exactly the same other than, and I spell out to them X, Y, and Z details that I'm going to do differently. I can tell them anecdotally, this is what I've seen in my patients and how they're doing, and this is what I offer to you. And then I really let them make the choice. And I think for me, in order to kind of get through that frustration and that curve and the honesty part of it, I have to just be direct with them and then let them choose. With regard to the frustration part, I don't necessarily share that level of detail with them. I may tell them this is an evolving technique in my practice. I've done hundreds of laparoscopic inguinal hernia repairs, which is the same operation. Admittedly, I've done substantially less robotic inguinal hernia repairs. However, it's the same operation. If I fear for your safety, I'm at the bedside and that's it. There's no further discussion. So I've tried to reassure them in that regard. I never push anybody towards it, though.
Wonderful. Thank you very much, Dr. Prabhu.